Very warm South African hello to our speakers, panelists, including government officials, the US Chamber of Commerce, CANSA CEO, private industry, and you, the audience, for your participation today. Apologies received from my colleague, Zadwa Sitole, our head of advocacy, who is unable to join us due to ill health. We thank her for all her valuable contribution towards the planning of this event. Apologies also received from Sandhya Singh, Director in the Cluster of Non-Communicable Diseases, National Department of Health, unable to join us also due to ill health. The Cancer Association of South Africa is a leader in the fight against cancer since 1931. Our mission is to be the preferred non-profit leader that enables research in lowering cancer risk, educating the public regarding symptoms, screening, and risk reduction, and providing care and support to all those affected by cancer. Cancer is committed to connecting people facing cancer with information, day-to-day help, and much-needed emotional support. We aim to ensure that cancer survivors and their loved ones do not face cancer alone. They receive stoma support, wigs, prosthesis, assistive devices, and medical equipment hire, clinical support, counseling, which includes face-to-face and telecounseling, support groups, and home-based care. Cancer recognizes that to survive in the current challenging climate, we need strong partnerships that will help us to reach our mission and objectives. We need to align ourselves with those that have a passion for cancer patients. Cancer has a wonderful opportunity this year as we celebrate our 90th anniversary. It is a remarkable milestone in our history. We aim to partner so that we can continue making an impact based on our values of leadership, improvement, passion, accountability, and integrity. Through the selfless support of our donors and sponsors, we can continue the fight against cancer in South Africa and advance closer to the goal of a cancer-free society in our generation. It is predicted that our country's economic recovery due to COVID-19 will take a few years. The need for our normal service continues, and even more patients and caregivers need help. We are aware of our duty to continue to educate South Africa about the cancer burden and to find innovative ways to help lower the cancer risk while providing support and care to the communities we serve. Now I turn over to our partner, Vani Murugan, who serves as the Senior Director of the Global Initiative on Health and Economy at the US Chamber of Commerce based in Washington, DC. Thank you.
Thank you so much, Lorraine. My name, as Lorraine mentioned, is Vani Murugan. I'm at the US Chamber of Commerce. For those of you who aren't familiar, the US Chamber of Commerce is the largest business advocacy organization in the world, operating in all 50 of the United States and in over 50 countries, including, of course, South Africa, to promote free enterprise and advance American trade and investment globally. The Chamber represents companies of every size and from every sector, working with over 100 AmChams around the world. The Chamber's global initiative on health and the economy was established on the grounds that strategic investment in health systems will drive and sustain economic growth and resiliency around the world. Moving to the topic at hand and building on what Lorraine just shared, as you all know, the impact of cancer on both patient lives and the overall economy continues to be devastating. Cancer remains one of the top causes of mortality around the world, despite that impact being hidden in a way from view during the pandemic. In fact, signs point to the burden of cancer getting worse due to missed screenings and treatments during the pandemic. At the Chamber, we strongly believe that greater investment in this space is needed so that patients can get screened and have sustainable access to both innovative and existing treatments, and can thus support economic recovery through a healthy workforce. We're very excited to convene our distinguished speakers and panelists here today. The first portion of our virtual event will comprise of prepared remarks from our government, civil society, and private industry representatives. And following that, we'll move into a question and answer portion with an expanded panel. So with that, I'll turn it over to my colleague, Danielle Munoz, to introduce our distinguished speakers.
Thank you, Varney, and hello, everyone. I have the pleasure of introducing our esteemed speakers today. Our first speaker is Ms. Elise Eubaia. Ms. Elise Eubaia serves as the CEO of the Cancer Association of South Africa, or CANSA. As CEO, she ensures that CANSA's networks collaborate with partners as wide as possible to mobilize resources and to contribute to control cancer in South Africa and Africa. Ms. Eubaia also serves as an EXCO member of the Non-Communicable Diseases Alliance for South Africa, as well as the Cancer Alliance. In 2015, she was announced as the African Continental winner for welfare and civil society organizations at Africa's most influential Women in Business and Government Awards. Our second speaker is Ms. Rashmi Ravigan. Ms. Rashmi Ravigan currently serves as Senior Manager within the Department of Trade, Industry, and Competition, responsible for the advanced manufacturing in the inward investment, attraction, facilitation, and aftercare division. Her role is primarily to facilitate, support, and engage foreign investors to place their investments in South Africa. She is also responsible for implementation and reporting on the Presidential Investment Mobilization Drive of attracting $100 billion over 5 years. She represents the division at various platforms, both domestic and international, in positioning, packaging, and profiling the business case for investment, as well as the sectoral opportunities in the advanced manufacturing sectors. Our third speaker is Mr. Zweli Bashman. Mr. Zweli Bashman currently serves as the Managing Director of MSD's operations in South Africa and Sub-Saharan Africa. Successes during his tenure include the signing of voluntary license agreements with low-cost manufacturing partners to allow the marketing of generic versions of MSD's HIV medication, as well as expanding access to treatment for people living with HIV and AIDS in Africa. Our fourth speaker is Professor Paul Ruff. Professor Paul Ruff serves as the chair of the Ministerial Advisory Committee on the Prevention and Control of Cancer, which was established by the South African National Department of Health. The committee advises the minister on all matters related to the prevention and control of cancer. And lastly, our fifth speaker is Ms. Candice Henning. Ms. Candice Henning serves as the Senior Manager of Value, Access, and Policy within the Middle East and Africa cluster of Amgen. She currently is based in the Dubai headquarters and has strategic oversight of value access and policy initiatives and the MEA region. She is also an active member of the Pharma Group, an industry body representing the Middle East and African countries. And now with that said, I turn to our first speaker, Elise, to provide her remarks.
Thank you. Good afternoon, ladies and gentlemen. Now, my presentation, I'm going to deal with the importance of early detection of cancer, the impact of a delayed cancer diagnosis on the employee and his or her family, how the employer can contribute to early detection, and how it all ties in with Universal Health Coverage and the Universal Health Coverage Day that we soon commemorate. I wish to start by presenting just a very high-level overview on the burden of cancerous disease. So next slide. Worldwide, 10 million people die from cancer annually, and mostly in low and middle-income countries. More than 19 million people develop cancer annually. And it's predicted that in the year 2030, these figures will rise to 26 million cases per annum and 17 million deaths. And even in countries with optimal health systems and services, the sad truth is that cancer cases are many times diagnosed at an advanced stage when it's harder to treat it successfully. Now, to reduce the burden of cancer, we need, before I go to that, just an overview on the South African profile. With our population of 58 million, our cancer cases in 2018, there were 107,467 newly diagnosed cancer cases. The cancer deaths in 2018 were 57,373. Premature deaths due to non-communicable diseases were a figure of 133,675, of which 23% was due to a cancer death. Thank you. And in a very recent study that was done by Percept, it was revealed that in 4 of our top 6 cancers in South Africa, 50% of those diagnoses were still in the very late stages of stages 3 and 4. There you can see for breast cancer, cervical cancer, female and male lung cancers, those diagnoses only occurred in the very late stages. Now to the next slide, please. Now, to reduce the burden of cancer, we need comprehensive cancer control plans that consists of risk reduction programs, early diagnosis and screening programs, cancer treatment, palliative care, and survivorship care. Now, early diagnosis of symptomatic cancers is relevant in all settings of them and for the majority of cancers. Therefore, cancer programs should be designed to reduce delays in and barriers to diagnosis, treatment, and care. Of course, prevention is always better than cure, so prevention is the most cost-effective public health strategy. But prevention alone is unfortunately not enough, as millions of people globally will still develop cancer because it's not all cancers are preventable, causes of cancer are multifactorial, and existing prevention strategies do not reach the entire populations. Therefore, diagnosis and treatment should be available, and the early identification of cancer should be prioritized. Detecting cancer at early stages enables treatment that is generally more effective, less complex, and less expensive. Palliative care and supportive care is, of course, essential in comprehensive cancer control, and providing access to pain control and pain relief is an international legal obligation of governments. And of course, survivorship programs should always be provided in a comprehensive cancer control program. And I'm glad to mention that South Africa do have a national cancer strategic framework that consists of all of these components. Next slide. Yeah, the World Health Organization provide a guide to improve early diagnosis, firstly, by improving public awareness of cancer symptoms, and to encourage people that when they detect these symptoms, that they should seek help and care. Secondly, that we should invest in strengthening and equipping health services and training our health workers for accurate and timely diagnostics, and to ensure that people diagnosed with cancer can then access high quality and affordable treatment timeously. But, next slide. Cancer screening and early diagnosis is, of course, then of essence. And firstly, the most effective way to detect cancer early is through detecting symptomatic patients as early as possible. But then also through screening which tests which aims at identifying individuals with suggestive of specific cancer or pre-cancer before they've actually even developed those symptoms. We have to find cancer before it spreads, when it's so much easier to treat. And of course, when screening is done and abnormalities are detected, that we should refer those for further follow-ups to indeed establish if it's indeed a cancer diagnosis, to be referred for further treatment. But screening is not always for all cancers very available and effective. And in generally, screening is more complex and resource intensive in many cases that than early diagnosis that requires special equipment and dedicated personnel. Therefore, patient selection for screening programs is also based on age and risk factors to avoid excessive false positive studies. Examples of cancer screening test methods are, for instance, the HPV testing for cervical cancer, or the PAP smear, the PAP cytology test for cervical cancer, mammograms for breast cancer, or PSA tests for prostate cancer. The bottom line is that cancer screening saves lives. There are, of course, many challenges towards, next slide. There are many challenges, and challenges are greater in our low and middle income countries for early detection, where there's a lower ability to provide access to effective diagnostic services, including imaging, laboratory tests, and pathology, all key in helping to detect cancer early and to plan treatment. And even when there's early diagnosis, unavailable referral systems results in delayed and fragmented care. Therefore, countries are all encouraged to strengthen early diagnosis, cancer diagnosis, and providing basic treatment so that we can all meet our national targets tied to the Sustainable Development Goals. So that we don't have delayed delayed cancer diagnosis. Next slide. Because delayed cancer diagnosis and the inability to provide treatment results in undue pain, suffering, and premature death. Detecting cancer early requires accurate understanding of current barriers to and delays in care, and once known, effective programs can be prioritized and resources can be allocated in a cost-sensitive manner. By taking the right steps to improve early diagnosis of cancer and ensure prompt treatment, especially for those high incidence cancers in South Africa, namely breast, cervical, and colorectal cancers, this will all result in more people surviving cancer. It will also be less expensive to treat and to care our cancer patients. Next slide. There are many barriers, unfortunately, in South Africa for early diagnosis, and here are a few to mention. Firstly, financial difficulty, delayed symptomatic presentation associated with advanced stages. Poor resource communities that are far from clinics. They are, of course, then low access to primary healthcare services. Lack of awareness of symptoms so that people don't present timeously. Long waiting times at facilities when they do present for follow-up. Bottlenecks in the pathway to cancer care. Lack of education at primary care, cancer screening behaviors. Cancer screening policies not implemented across board, the lack of diagnostic services, and the lack of expertise, a lack of human capital and skilled personnel, all contribute to late diagnosis. Slide. In 2010, the total annual economic cost via healthcare expenditure and loss of productivity was estimated at $1.16 trillion. Therefore, early detection will greatly reduce financial impact. The cost of treatment are so much less in earlier stages, so that we can allocate more resources to work and support families if accessing effective treatment in time. Next slide. Therefore, the World Health Organization strongly recommends that governments should invest in basic, high-impact, low-cost cancer diagnosis and treatment services. That we also should lower the need for people to pay for care for themselves, prevents many from seeking care, and that we should actually implement employee wellness programs so that we can take early diagnosis and screening services to our employees. Next slide. No employee wants to hear that they've got cancer. The post-shock of a diagnosis, the reality of the associated healthcare cost and low productivity, and the realization that they might need time off, and the fear of a possible job loss Employment gives psychological and financial health benefits like healthcare, and that is all at risk when you are now diagnosed with cancer. Therefore, workplace accommodations like flexibility and sick leave can offset those negative impacts on the emotional dealing with a cancer diagnosis. But unfortunately, we do see that low income and majority workers are less likely to work in work environments that are accommodative of their needs. Therefore, strong workplace policies are needed to support our cancer patients in the workplace. We want to call actually, next slide, on our businesses to be industry leaders, to embrace their corporate responsibility and helping their employees to stay healthy. They will to be proactive by ensuring that the employees are educated on their cancer risks and how they can actually reduce their risks, by encourage and promote good habits, by promoting healthy nutrition, making healthy eating accessible by what they offer in their canteens to their employees, bringing cancer screening to the workplace, go smoke-free, and promote physical activity. So we can actually, the employer can play a huge role by bringing screening benefits to their employees so that we detect cancer early. So please, the call is on our businesses. Be a leader, be proactive, and bring screening to your employees to predict your best investment, your employee. Next slide. Next slide, please. We are soon going to commemorate Universal Health Coverage Day on the 12th of December, when governments globally recognize the importance of universal health coverage to tackle the burden of MCDs. But companies can also support universal health coverage by bringing screening and early detection of cancer to their workplaces. We should leave no one behind if we want to achieve health for all by 2030. Employees should have access to quality essential health services without the suffering of financial hardship. And to prevent future pandemics and achieve health and well-being for all, we should focus on equity, investing more in health and allocating resources efficiently and equitably. COVID has already exposed long ignored risks like inadequate health systems, gaps in social protection, and structural inequalities. The theme for this year is then to leave no one behind and to invest in better health systems. Therefore, we should all embrace strategies to improve early diagnosis, embrace universal health coverage, to reduce financial and give financial risk protection to everyone in South Africa, to access healthcare services, to have access to medicines and vaccinations to relieve the cancer burden. We should all embrace efforts to meet our sustainable development targets by improving health, environmental health, reducing social inequalities, and thereby also to reduce the cancer burden. Therefore, I want to conclude. Delayed diagnosis, no treatment access contributes to death. And a cancer death is a tragedy to family, community, and the workplace. Solutions is comprehensive health systems response, service integration, high impact and cost-sensitive interventions, early diagnosis, increasing cancer awareness, health participation, clinical evaluations, and staging and improving access to care. Therefore, public, private, and civil society should all work together on early detection programs in influencing screening policies and guidelines. I thank you.
I never went for any test, never.
Wellness days are basically taking the services to the corporate. A lot of people cannot get away to go for these screening, to go for pap smears, breast examinations, PSAs. If they don't have leave, they've actually got to take a day's unpaid leave. So therefore it gets neglected. But now it's available on my doorstep. I have the opportunity.
Bankman will definitely recommend Cancer Wellness Service to any other corporate company. It's a way of companies investing in the employees' health and ensuring a healthy and productive workforce.
It's a very personalized service that we're giving to people at their workplace.
This is important as members at times can be anxious about this invasive procedure.
They sent an email reminding us this is the day now. That's when I decided, no, let me go and get tested. She did the pap smear, and then she also did the physical test on my breast. She felt a lump. Hey, I couldn't sleep at night. Hey, thinking, hey, I'm going to die.
When a wellness day is done, it's not only the screening. We also have an exhibition where they can see all our models. They can look and see what the lungs look like. They can feel our models, the breasts. They can feel the testes, what it feels like to have a little lump that's like the size of a pea in the testes.
The doctor called me and she said to me, you don't have cancer. However, you've got cysts. But she was able to remove the cysts immediately.
Besides the screening, besides the exhibition that we have, we also do a health talk. So they're also getting information, and suddenly they can ask the questions that they've always been afraid to ask.
This interaction is priceless and a great value add to our members.
This is a great initiative. I wish that everybody could attend.
After we've done a wellness day at a corporate, the corporate will then get a very comprehensive report back to say the wellness of your corporate is either low, moderate, or high.
Cancer wellness programs are a great way of contributing to the Sustainable Development Goals by providing good health.
I have realized that it's good to know. If you know, your lifestyle changes, everything changes.
The feedback that we've had, breast examinations where we've picked up a lump, pap smears that have come back with abnormal cells. These are people that would never have gone for the test, and the feedback that we've given, thank you. Thank you that you made yourself available. Thank you that I could get that early diagnosis.
Even though I do not have cancer, but I'm taking good care of myself because of that process that I went through.
Thank you. Maybe I should just mention that this video was made before pre-COVID. That's why you don't see any masks. We of course now wear our masks. Thank you.
Thank you so much, Elise, for that really informative presentation. And it's always nice to hear the patient voice and have that reminder. That's why we're all here today. So it was wonderful to watch that video as well. So we'll turn it over to Rashmi now.
Good afternoon, everybody. Thank you to the US Chamber of Commerce and the organizing associations and my fellow panelists for giving me this very important platform to share with them on this very important conversation. And so today I'm going to look at why a healthy workforce is critically important to the recovery and specifically focusing on the economic side of things. And of course, I would look at it from three different perspectives on the importance of a healthy workforce to economic recovery. I think we all are aware of what has happened in the last 2 years. We've seen unprecedented shifts, health pandemics, non-communicable diseases and communicable diseases, global and local lockdowns, travel bans, less than
I think we may be having some connectivity issues with Rashmi.
I'm not sure if you can hear me on this.
Yes,
Okay,
we
so
can.
I've
Thank
just
you,
switched
Rashmi.
on to another system, and apologies for that. So as I was saying, we all really in the last 2 years have seen unprecedented shifts, global and local lockdowns, health pandemics, both communicable and non-communicable, as well as the COVID pandemic, travel bans, less than 100% workforces at manufacturing facilities, supply chain disruptions, job losses, strained health systems, increased fiscal strains, a lot more demand for products, shortages of products, and the list can go on. But what we're reeling from is the debilitating effect on the lives of people, the economy, and within the globe. Since the onset of COVID, we've seen disruptions the world over. And with South Africa, it's had to deal with the health system, the livelihoods of people, and the economic disruptions and global supply chain disruptions on our local economy. What has this meant for the South African economy? It has meant rethinking, reshaping, and re-strategizing. It has also meant that employers now have to make plans to deal with the effects and the effects on its workforce. And whether you are burdened by communicable or non-communicable disease and COVID itself, but it does require that you adjust, adapt, and be agile to be able to be practical in the way that you are implementing things as we recover from this particular pandemic. It's also brought about new paradigm shifts in thinking, new platforms in terms of using more virtual and digital platforms. It's brought about adaptability and resilience, and companies now need to deal with itself. And so with COVID and the impact on the South African economy, the president announced an economic reconstruction and recovery program, focusing on 4 high-impact interventions and the need to build capability and capacity within the South African economy, thereby allowing for more manufacturing to take place, developing and manufacturing PPE, diagnostics, and pharma products to ensure that the livelihoods are not further devastated, and building on the healthcare system to ensure that the production of products can get on the shelves and still retain within affordability. This has also meant that industrialization has become more aggressive. And as a result, the economy has to produce more protective personal equipment, more ventilators, more diagnostics to deal with not just the pandemic, but with any healthcare issue, and to be able to be in a position to be able to help the economy as well. This has also meant that the partners and the cause is a united one. And this, what do we do and how do we continue? And how does this affect the health of workers itself? This has meant that it's not only had an effect physically on employees, but certainly on the mental health as well. What has this meant for companies and for government? It has meant introducing healthcare programs for workers. It has also meant introducing measures for the safety of their well-being, providing them with the tools to do their work from home, putting safety measures in the workplace, and monitoring and checking on the employees' well-being as well. Because if you don't have a healthy workforce, you are not going to be having a high improvement in terms of productivity, an increase in the volumes linked to production, and economies of scale that links to affordability and lowering of prices, and also in terms of getting the mass production that you need to be able to have people accessing the product itself. With this particular reconstruction and recovery program, industrial growth is one of the pillars. And as the department responsible for industrialization, there is a need for us to increase capacity and capability. And not just increase capability and capacity with manufacturing, but increasing the number of international companies that come and place their manufacturing facilities on the South African soil, and being able to partner with local companies to increase that production. integration, thereby taking the best of what is available outside of South Africa and bringing it onto the South African shores. This allows for the agility of both private and public sector in working together to be able to strike these strong partnerships, allowing to commit on targets and being able to drive implementation of increasing scope, scale, and capability and production with no or little interruptions to their work. This has also required that strict health protocols be introduced in the workplace. All of this cannot really be executed without a healthy workforce. And whilst none of us ask for illness or disease, it cannot be helped. What we do need to do is to be able to see how we manage the situation, how we manage the matter, and how we support within the environment, at work and at home, to be able to allow this work to be executed with minimum disruption. As a department, we've also introduced health protocols within the workplace. We continue to encourage vaccinations against the pandemic. We continue to increase production and capacity and capability of PPE, of ventilators, of diagnostics, and certainly now of vaccinations through our partnerships with our local companies, such as BioVac and Pfizer and Aspen and J&J. And the same can be done for oncology products, with international companies partnering with South African companies and engaging with government, building those strong partnerships so that we are all able to support the ecosystem and the value chain. Because really through the development and integration of the value chain, are we able to produce the goods that are required to be able to take the nation forward. The second perspective is access and cost of medication. Whilst cancer treatment is high and not necessarily affordable to everybody, that's the reason why we encourage companies to increase their local production and increase the partnerships with local companies to be able to produce these products again, choosing South Africa as an investment destination, choosing South Africa as a manufacturing base to be able to put their products so that they can not only access the domestic markets, but also allow for their products to be accessed on the continent itself. Whilst costs are high and whilst medicines are high, we encourage, from a accessibility point of view as well. And there are many support measures, many instruments that you can use within government and outside of government to be able to put these structures in place. The third perspective is as a manager, managing somebody with this, with a disease or managing an illness itself. And of course, in the case where we're talking about cancer, of course, as an employer, as a manager and having a span of control of people in the organization, it's always important to bring these conversations to the forefront in building a healthy, engaged, and empowered workforce. A number of employees always feel anxious and stressed for a number of reasons, and it's most important to reassure them, empathize, and support your employees, taking into consideration that when allocating work, not making the person feel non-productive, but taking into account that the person may not be able to work at their full productive capacity. And so it's important that we take all of these factors and that we empathize with the employees, we support the employees to be able to have that healthy workforce that we require. Because it's only through that healthy workforce that we can increase productivity, we can increase the volumes that we are looking for, we can have the economies of scale, thus reducing the cost of treatment, have the mass production so that we can have it access to not just our markets, but the rest of the world, and have accessibility, affordability, and availability of medicines to the citizens and to the workforce that so require it at this time in need. And so I would like to thank you for the opportunity to engage in this session, and I look forward to the insights of the other panelists and the participants as we bring this conversation to the forefront of all our conversations. Thank you.
Thank you so much, Rashmi. And in particular, thank you for your adaptability to move between various modes of communication there while you were addressing your connectivity issues. You mentioned during your talk the partnership potential with private industry in the cancer space. So that connects us well to our next speaker from MSD. So Zweli, over to you.
Thank you very much. Good afternoon, all. My name is Zweli Bashman, Managing Director at MSD across Sub-Saharan Africa. And I'm also the Deputy Chair of the US-South Africa Business Council. I address you during a time when the world continues to deal with COVID-19 and the impact of innovation in the healthcare space is clear for all to see. One area where access to innovation is particularly compelling is in the oncology space. 20 years ago, a lung cancer diagnosis was considered to be a death sentence. Since then, the 5-year lung cancer survival rate has increased by 15 to 30% globally. Advances in cancer treatment have helped to improve the 5-year metastatic skin cancer survival from 5% to 50% in the past decade. And one of the major factors that has led to the marked improvement in survival rates has been the development and introduction of innovations such as immunotherapies. Now, I've personally seen and experienced the impact of innovation in the oncology space within my own family. In 2012, my father was diagnosed with stage 4 colon cancer. He later passed away in 2017. And whilst his death was devastating to us as a family, the 5 years that we had with him were incredibly enriching and allowed us to live with purpose, share experiences, create memories, and say all that needed to be said. At MSD, we are committed to broadening access to innovative therapies to patients across the world, and my mandate is to avail access to patients on this very continent. This is a mandate that is shared by multiple stakeholders in the healthcare value chain. As a manufacturer, we must innovate and develop therapies that address the areas of highest need. We must also develop access solutions that speak to the financial constraints of the people of this continent. Governments must create enabling policies and legislation that will encourage the introduction of innovations in a sustainable manner. They must also create robust healthcare systems that are able to diagnose patients early and suitably refer them to well-equipped institutions that can administer the most suitable treatments and ensure that these patients get the best possible outcomes. Advocacy groups, patients, and society at large must seek awareness and education. They must encourage early health-seeking behavior and raise their powerful voices to drive all parties involved to act in the best interest of the patient. We all have a responsibility to minimize avoidable death and suffering. Yet when we discuss access to healthcare, the primary point of departure is often cost containment. However, over the past 2 years, we've seen that the health of our people is inextricably linked to economic growth. There is no actuarial calculation that could accurately evaluate the value of the 5 years that I spent with my father. Rather than focusing on cost containment, governments should embrace health expenditure as a vital investment to promote better health and economic growth. This is a discussion that we at MSD have been having with the Ministry of Health. The legislative landscape in South Africa does not fully support widespread access to innovative healthcare. There is no clear pathway to avail innovative access models to patients in the country. Value-based care remains a concept that is simply not implementable within the country. There is an emphasis on low cost versus value, patient outcomes, and overall cost effectiveness. We must also directly address the matter of wealthier nations adding countries like South Africa to their list of reference countries from a pricing perspective. The concept of equity is probably more important in the healthcare space than any other space in modern day society. So CANSA and its partners within the Cancer Alliance have identified the need for legislative reform and are currently undertaking research into the introduction of cancer legislation in South Africa to guide the screening of cancer, treatment of cancer, and the prioritization of cancer within the national healthcare policies. At MSD, we support and applaud this. We are committed to continuing this journey of co-creating a healthcare ecosystem that meets the needs of our people. Our partnership with stakeholders such as CANSA and other advocacy groups, medical insurers, medical societies energize and invigorate us to continue tabling solutions that we believe will address the shortcomings that impede widespread access to innovation, more specifically within the oncology space. Thank you very much.
Thank you so much, Zweli, and thank you for sharing your personal story as well. I think that was really compelling, and you touched on a lot of really great points that we'd like to pick up in the Q&A portion as well. Now we will turn to, we originally were turning to Professor Ruff. He's just running a little bit late, so we'll be turning over to Candice at Amgen as well. Thank you, Candice.
Thank you, Varney. Lovely to see you all tonight. Thank you for joining. And thank you to the US Chamber of Commerce for this opportunity to present to you tonight. I'm very privileged to be wearing two hats tonight, or not really two hats, one hat with two bands. Firstly, I represent Amgen, who, if you're not aware, is an American biotechnology company with a mission to really serve patients, trying to bring innovation and improve access to our medications to all patients that need it. And secondly, as the Oncology Working Group of the Pharma Group, which is an industry body in the Middle East and African region. I think if I can just say one comment is, if you look at the level of industry participation in this meeting, I really think it illustrates the dedication and the sort of willingness to really support in the fight for cancer and to help our patients as best as possible. So the aim of my presentation tonight is really to give you an overview of one of the projects that we've been working on as an oncology working group. And this is an IHE comparator report on access to cancer care in the Middle East and Africa region. Next slide, please. So this is just to give you an overview of who the Pharma Working Group is made up of. I see Gertrude is on the call with us. It's our formidable leader in our group. And it's really just been a privilege to work alongside all of these folks from various companies in the Middle East Africa region. Next slide, please. So, I mean, you've heard from multiple speakers tonight that cancer is a global policy issue. We know that, we've seen that. And as these populations start to age, we know that the increase of the burden of cancer is going to be to individuals and then also to our healthcare systems. And although these significant advancements have been made in diagnosis and treatments, which really does improve patient outcomes, can change the cancer profile from being acute to chronic, and also increases the number of cancer survivors. However, as Willie mentioned, sometimes what we're finding is there's really restricted or no access to innovative diagnosis or treatments, and this remains a challenge. What we're seeing in the shifts in healthcare that we're seeing is we're moving towards more of a personalized healthcare space, which will require policy adaptations to even further facilitate the use of biomarkers in diagnosis and also the treatment customization for this personalized healthcare. Next slide, please. So what did the Oncology Working Group do? We went and we looked at some best practices. And what we found was a comparator report that was done in the European region in 2019 that really looked at the burden of disease, access to medications, costs of cancer across Europe. And what we did is we decided to reach out to the Swedish Institute of Health Economics and to try and replicate this and expand this to the Middle East and Africa region. There are some links provided in the bottom of the slide if you are interested in any of those reports. So we partnered with Thomas and his team at IHE. Thomas has got a wealth of experience. He's an Austrian health economist, and he's been working at IHE since 2012. He's co-authored several articles addressing cancer specifically in Europe, and his focus really focuses on the analysis of access to new cancer drugs and the economic costs associated with cancer. He holds a PhD in economics from the Lund University in Sweden. Sorry, next slide, please. So what does this comparative report look like in MIA? So there are two phases to this. So there was a policy report on the current state of cancer care in these 9 Middle Eastern African countries. You can see them listed at the bottom of the slide there. Phase 1, really, Thomas and his team really did some robust country sort of desk research where they wanted to try and pull all available data sources to look at a comprehensive assessment of the current state of cancer care in the Middle East and Africa region. What they then did is they took this reports or the sort of findings that they had, and they had these 3 sort of virtual expert workshops where they ratified some of these findings. They also identified barriers in this to effective, efficient, equitable, and responsive cancer care in the Middle East region. And then what we tried to aim to do was formulate some general and country level policy recommendations so that we could really improve that cancer care across the Middle East and Africa. So what were the objectives and the outcomes of this report? Well, firstly, we wanted to examine and drive awareness on focus areas of cancer-based care on key performance indicators. And the guidance was really provided by leading European policy expert, Tich Albrecht. And we wanted to validate these findings from phase 1, as I mentioned a little bit earlier, and really get some guidance from these national experts within the MIA countries. As I mentioned, it was in these workshops that are of lasting about 1.5 hours, 3 of those. And we had over 5 representatives from South Africa in that group, whether it was clinicians, patient representatives, or health policy experts. And then what we aim to do is bring this all together and really derive these policy conclusions and recommendations based on best practice examples that we'd seen in other MIA countries. So that's the beauty of a comparator report, is we could say, what is happening in other MIA countries that we probably give recommendations for other MIA countries. And then also from our European reports, we could build some comparisons based on that. So if you look at the bottom of the slide, you'll see that these are the sort of key indicators or the key cancer care elements that we were looking at. We wanted to look at prevention, early detection, treatment, survivorship, obviously all underpinned by the governance of these, as well as achieving some goals. We want to support research and access to innovation, one of our key goals. But at the same time, we want to reduce inequalities and make sure that care is equitable across all patients. Along with prevention, early detection is really sort of, how do we reduce that cancer risk? Are there ways to improve policy to do that? And then improving cancer survival and quality of life, again, starting with early detection, how does our treatment fit in, and how does that affect survivorship? Next slide, please. So this is a brief overview of the cancer care in the Middle East and Africa reports. And I'm happy to say that it was published last week, or on the 24th of November, on the IHE website. There is a link provided to that, but we will also leave it to the local industry body, IPASA, to really roll it out in country. But there's 5 main chapters. So the first chapter focuses on the introduction. So what does cancer and policy look like in the Middle East and Africa? What is the scope of the report? In the second chapter, we've got the burden of cancer. What is the burden of disease? Cancer epidemiology. I know that we had some presentations earlier looking at the epidemiology and those stats that we saw there. This kind of brings it all together and puts it in comparison to some other Middle East and Africa countries. What is the economic burden of cancer? And then what are the key findings with regard to the burden of cancer? The third chapter really looked at the organization and the funding of cancer care. Where does this healthcare spend come from? And how does universal healthcare coverage really fit into this? And with that, what do the country profiles look like? And what we'll see later at the end here is we've got some country profiles, but how does this really pull in, and how does this all come together in this country profile? And then the fourth chapter looks at current state of cancer care. So what does the access to cancer care look like? What is the governance structure surrounding this? What does prevention, early detection, diagnosis and treatment and survivorship look like at each country? And with that comes the 9 country profiles with policy recommendations on how to improve this going forward. Next slide, please. So the main findings, overarching findings on the cancer report was that, as we know, cancer is set to become the #2 cause of disease burden in Middle Eastern and African countries. The number of newly diagnosed cancer cases has been increasing across all the MEA countries over the past few years. An interesting observation was made earlier by one of the speakers talking about the economics and resources and how that actually relates to outcomes. What we've seen in this report is that Egypt and Morocco have the lowest survival rates in cancer, whilst more wealthier countries such as Kuwait, Saudi, UAE have the highest survival. And that hints to a positive correlation, again, between survival and economic resources. Majority of our countries do have a national cancer plan, but the actual implementation, and there's been a lot of competing resources and competing priorities, but the implementation of this remains questionable. And what are those barriers to implementation? Most of our countries have got an absence of population-based cancer registries. And without the availability of reliable and up-to-date information, it's very hard to sort of inform cancer policy, especially in some of these lower income countries. Providing access to good quality care and good cancer care still remains a challenge, with universal health coverage ranging from 16% in South Africa to 100% in the Gulf countries. But this was really targeted at their own citizens and not really for any expats. What is the main principle of pricing that came out of this report? What we see is that it's really external reference pricing. Reimbursement is a question of tendering and negotiations. The value of our drugs and the value they bring to patients, like Zweli's father, is really not being brought into the equation at all. Next slide, please. So this gives you an idea, just a snapshot of what those cancer policy reports or the country reports actually looks like. Yes, it's got the cancer epidemiology, but it also goes into what the economic resources are behind cancer. Where is the national cancer plan? What are some of those policy recommendations that we're going to be having to implement to really take cancer care to another level? Next slide, please. So this was just a quick thank you. So these were our South African experts that will actually form part of those working groups. Remember I said those 3 touch points that we had. So thank you to our South African experts for making this report possible. And thank you once again for the opportunity to present to you today.
Thank you so much, Candice, and for providing that perspective, not only demonstrating the burden of cancer and what can be done in South Africa, but for the region as well. So with that, I'll turn it over to our final speaker, Professor Paul Ruff.
Thank you very much. I was asked to do this yesterday, so I haven't prepared any slides, but that's not a problem. Before I start, I just want to make 2 comments about the presentation that Candice made. The first of all is that there's a little bit of an error in your last slide about the participants in the AHE report, because you put down there the name of the hospital as an individual. There's no, Charlotte Macheke died about 90 years ago, and the hospital is named after her. She's not someone who did the work. Somehow that got muddled up. So if that slide can please be corrected to show the appropriate people involved. The second one was obviously, as you know, I was involved in that, and I actually sort of rewrote a large part of the South African section of the document. I have 2 concerns about that document. One is that South Africa is the only sub-Saharan African country that was looked at in that document. All the rest are either North Africa or Middle Eastern countries. So I think it's not a good reflection of what is going on definitely not in sub-Saharan Africa, which is South Africa, I think, is quite different to other places. So I think that that document would would be better if they included other sub-Saharan African countries. The other problem with the information, a lot of it was based on sort of in estimates and is not as accurate as it could have been, because a lot of the data that's needed doesn't exist. And so it wasn't an easy document to actually develop. But I think the general sort of gist of what it was saying was very useful, but I think it might be opportune to take that a little bit further and to look more at other sub-Saharan African countries and to maybe get some more data, although it is very difficult to get because we know that the cancer registration, and you mentioned about the aim to get population-based cancer registration, is very difficult. In South Africa, does have population-based registration, but in very limited fashion. We have a new registry in Ekurhuleni, and we have an old population-based registry in the old Transkei, but it's very limited. The major cancer registration is pathology-based, and the development of proper population-based registries requires a lot of expertise and money to do it, which is lacking. And in fact, it's a big problem we have in South Africa. And I mean, I think that sort of leads into what I was going to talk about cancer diagnosis and detection. And I think that I would fully agree that it's very important to try and enhance cancer registration, but the only way we're going to get more accurate cancer registration is to get more accurate cancer diagnosis. Now, it's a problem that is lacking in this country and in many countries in the world because many patients with cancer do not get diagnosed and definitely do not get a pathology-based diagnosis. I mean, the classic example, and in fact, you spoke about cancer control plans. We're in the process of completing the lung cancer policy and guidelines for the National Department of Health, which hopefully will come out in the new year. It's just been delayed because of problems with the costing. All the actual scientific work has been done. And one of the major problems with lung cancer is that it's not being diagnosed. And that's why if you look at lung cancer statistics in South Africa, they are very limited. I mean, I think the numbers reported, although it is still goes there as the third most common in men and fifth most in females, it is still grossly underdiagnosed. And that is because people don't think about cancer. And in fact, a lot of the problems that lie not with patients, but actually with the system. And in fact, the biggest problem, I think, is the healthcare system. Now, we have a healthcare system in this country which is based on, primary healthcare going to secondary healthcare, tertiary healthcare. But if patients are not recognized as having cancer or potentially having cancer at the primary level, you can have the best medicines in the world and the best technology in the world. It's not going to help because if you're not diagnosing, you can't treat. Now, lung cancer is a classic example of that. People go to the doctor with a cough. The doctor gives them an antibiotic. They don't get better. They go back and get another one. They don't get better. Then they decide, oh, they must have TB. And they're putting on TB treatment, as a result of which they don't get better. So either the lung cancer is never diagnosed and the patient dies before diagnosis is made, or they're diagnosed so late that they're not actually candidates for any definitive treatment. In fact, the only cure for most lung cancers is surgical resection. The data we have, probably only 2% of people with lung cancer in this country come to surgical resection. And that's because the diagnosis is being made too late. And everyone says, oh, patients present too late, they present with advanced disease. Sure, that does happen. But if we had a more vigilant and a more aware healthcare system where healthcare professionals at the primary level, at the GP level, and I'm not talking only about doctors, I'm also talking about nurses, I'm talking about pharmacists, about all people in the healthcare and that are healthcare professionals, to recognize that cancer exists, then you would go a long way towards getting diagnosis. Now, lung cancer is an example where this is not done, and that's why lung cancer is so poorly diagnosed in this country. Other cancers are better. I mean, breast cancer, there is better awareness and diagnosis. That's why if you look at the statistics from the cancer registry, breast cancer has increased considerably in the last 10 years. Now, is this because there's more breast cancer? We don't know. Everyone says there is, but I'm not sure if that's true. I think the real reason is that there's more diagnosis. People are being diagnosed quicker and diagnosed earlier. Because I think breast cancer, for example, there is more awareness. It's because there have been a lot of campaigns. There's a lot more awareness about breast cancer. And obviously, clinically, breast cancer is a lot easier to diagnose than lung cancer. And if you look at the statistics on the cancer registry, and this is pathology based, you've gone from 5,500 to 9,500 new patients a year, which still may be an underestimation, but there has been an improvement in the diagnosis of breast cancer. And a lot of it is because of awareness at the primary care level. And awareness is not just at patient level, which is very important, but also at healthcare professional level. There's also been a lot of support from the NGO sector, especially in breast cancer, that has improved things. So, you know, a lot can be done to improve the diagnosis of breast cancer, of cancer, and to make your diagnoses early. But we still have a long way to go. I mean, if you look at breast cancer and you compare statistics for early versus late breast cancer, and you look at data from Kusani Baragwanath in Johannesburg versus patients from Gray's Hospital in KwaZulu-Natal, at Charlotte, I mean, at Kusani, you have 50% early, 50% late, whereas in KZN, it's 30% early, 70% late, or even worse. And why is this happening? It's because in the systems work better in urban Johannesburg, where patients can get to the correct centers quicker than in rural KZN, what this is more difficult. And unfortunately, rural KZN is probably more representative of what goes on in the country than, you know, urban Soweto. So, you know, things can be done to improve early diagnosis from just purely getting more awareness at the healthcare professional level, as well as at the patient level. Other of the major cancers, what we've sort of colloquially called the big five, breast cancer, lung cancer, I mentioned. Cervix cancer is a cancer where there has been awareness, but it is not adequate. But if you look at statistics, cervical cancer has not increased significantly in the last 10 years. The reason for that may be that the diagnosis may have been better early on because there was more screening. We don't know. We haven't yet seen the impact of the HPV vaccination program on the incidence of cervical cancer because it's too early. We're only looking at about 10 years or even less. I think it's only about 7 or 8 years that this program has been ongoing. And so it's far too early to see if there is an impact from HPV vaccination, but obviously moving to the future, we hope that this will happen. Unfortunately, the HPV vaccination program has been quite significantly retarded by the COVID pandemic. And, you know, at one stage, they were getting over 90% penetrance in young girls at schools age 9 or 10, but they weren't unfortunately vaccinating young boys yet, but that's still to come. But I'm very concerned that this program is going to lose its impetus because of the impact of COVID-19. And in fact, COVID itself, as just to take it from there, is actually having a very negative impact on people's outcomes, not because that they're dying from COVID, but they're dying from other diseases because of COVID, that people with diseases are either being diagnosed far later or not being diagnosed at all. And this is not just in South Africa, this is a worldwide phenomenon. And I mean, I think that the biggest disaster from COVID is not the deaths from COVID, but the deaths not from COVID because of COVID, because the healthcare system has been so badly damaged by the impact of COVID. And it's something that needs to be really looked at. And from a cancer point of view, there is a lot of work that needs to be done. And it's something which I think we're going to be needing to do a lot of research in the next few years to really tease out exactly what has been going on because of the effect of COVID on cancer care and where things have gone wrong because of COVID. But also, on the other hand, where things have gone right. There's always a silver lining. And one thing COVID has done is it has improved vaccine technology enormously, and maybe it'll lead us to having better cancer vaccines and better vaccines for other viruses related to cancer. So there may be a silver lining from COVID, as well as all the doom and gloom, but we'll have to wait and see what happens. I mean, going back to the sort of major cancers and early diagnosis and screening, as we mentioned, cervical cancer screening does exist in this country. It is far from adequate. It's done in a patchy way. There's debate on what is the best way to do screening. At the moment, liquid-based cytology is the standard. I think that HPV DNA PCR is a better approach, and it's something which I think in the long run is going to be more feasible and easier to do. So there is room for improvement there. And obviously with better prevention and screening, hopefully we'll reduce cervical cancer, which still remains the major killer of women with cancer, especially in rural parts of this country. Breast cancer we've spoken about. Breast cancer screening and awareness and diagnosis isn't bad. It's better than with other cancers, but it still has a long way to go. Is there a role for screening? There's debate. Mammography is not the be-all and end-all when it comes to screening for breast cancer. Data has shown that mammography is not as good as has been thought. And in fact, studies have sometimes shown that clinical breast exam in the long term is just as good as mammography and ultrasonography when screening general populations. But obviously in populations where the risk is higher, it becomes more important. But it's at the moment when we have mammographic screening, it's done in an ad hoc fashion. It's done by certain NGO groups who push it in certain areas, which is great, but it doesn't help everybody. What is needed is a more controlled plan and way to actually have equitable screening for the appropriate patients throughout the country, and that isn't happening. But you know, there has been a lot done in breast cancer compared to other cancers. Colorectal cancer is a major problem. It's the second most common cancer in men and the third most common in women, but it is still underdiagnosed. Now, if we look at screening for colorectal cancer, colonoscopy and removal of polyps is definitely the best way to go. In the United States, they've reduced the incidence by a third by doing colonoscopic screening and removal of polyps. In this country, nobody has screening colonoscopies unless they have either a strong family history or they've had a prior malignancy. Most colonoscopies are done more as based on symptoms rather than a screening. But colonoscopic screening is not possible routinely in the country. There are some new studies that we're looking at other forms of screening. And we're looking at a study that in collaboration with people at Columbia in New York, looking at stool testing, you know, at a more sophisticated DNA testing of stool. And we're also looking at a collaboration with Johns Hopkins in Baltimore, looking at having various panels looking at sort of liquid-based liquid biopsies, looking for DNA and methylation signals, colon cancer screening, as well as other cancers. So there are methods of screening for colorectal cancer, which I think in the future will be more feasible than routine colonoscopy. But colorectal cancer still remains a major problem in this country, and we still have a long way to go with it. The other important cancer that I haven't mentioned of the so-called Big Five is prostate cancer. Prostate cancer is far and away the most common cancer in males in this country. And you get a two completely separate streams of approach to prostate cancer. In the wealthy, insured community, we have people doing PSAs every 5 minutes, getting hysterical and doing all sorts of unnecessary MRIs, biopsies, etc., and that is counterproductive. On the other side, in the public sector, we have patients that become dependent on permanent inverting catheters because their tumors are left so long. Radiation is not available to adequately treat them, nor is surgery. And so the management of prostate cancer in the public sector leaves a lot to be desired. The awareness of prostate cancer at the primary care level is not adequate. We have a long way to go. And for a disease that, is diagnosed in about 7,000 men per year in this country, far and away the most common cancer in men in this country, the management of prostate cancer in this country is shocking. We still have a long way to go. Now, we have to have the right balance between appropriate screening and inappropriate screening. We need to move away from sort of knee-jerk screening and unnecessary screening that happens in some parts of the private sector, but we need to have an approach where patients are diagnosed far earlier in the public sector. Awareness by healthcare professionals at the primary care level, be it GPs or be it primary care clinics, when men have symptoms, that these are patients are followed up more quickly, so they don't end up with these advanced diseases that aren't able to be adequately treated. Also, awareness in the public is not adequate. I think, unfortunately, prostate cancer, because it happens in old men, not in young women, and I'm not being sexist now, but there's a lot more concern and awareness of breast cancer than there is for prostate cancer, which tends to be ignored because people say, oh, this is in old men, it's not a big deal. But in reality, it is also a big deal. We need to have the same degree of awareness and concern for prostate cancer as we have for all other cancers. All patients have the right to receive appropriate and adequate treatment. And within the confines of the limitation constraints that we have, we still can provide patients with cancers with far better prevention, far better early diagnosis and screening, and ultimately far better treatment that doesn't cost millions and millions of dollars, but can be done within our system, provided that there are conscious efforts to get these plans together and these guidelines and policies together, but also to implement them so that there's equitable access to early cancer diagnosis, cancer prevention, and early treatment throughout the country. And stop there. Thank you very much.
Thank you so much, Professor. And thank you as well for joining last minute. As Lorraine mentioned at the beginning, we had, unfortunately, our Department of Health representative drop out due to illness. But it was wonderful to hear from you sort of the distinctions between the various cancer types in terms of their unique challenges. And critically, you mentioned, the impact of COVID on mortality from diseases like cancer that are not, on its face related to COVID. So that's something that's really critically important to recognize. So I'll turn it over to Danielle to introduce our additional panelists, and we'll move into the question and answer portion of the event.
Thank you, Varney. We now have two new speakers joining us for the second portion of the program. Our first speaker is Ms. Gladina Lutz. Ms. Gladina Lutz is the Director for Health Innovation at the Department of Science and Innovation in South Africa, and as such is responsible for the implementation of the health components of the bioeconomy strategy for South Africa. She concentrates on enabling research and innovation that leads to discovery and evaluation of new drug and treatment regimes, the development of new vaccines and new robust diagnostics, as well as the development of medical devices. Our last speaker who will be joining us today is Dr. Zainab Mohammed. Dr. Zainab Mohammed is a clinical and radiation oncologist and the head of the clinical unit at Groote Schuur Hospital and at the University of Cape Town. She runs the lymphoma and composite sarcoma clinics and provides radiotherapy services to clinical hematology. Her research interests include HIV-associated malignancies and lymphomas. She also has a special interest in palliative care and is co-facilitator of an online palliative care course offered to oncologists by the University of Cape Town. And now I turn back to my colleague Barney to moderate the Q&A.
Thank you so much, Danielle. And thank you again, distinguished panelists, for joining our speakers. If anyone in the audience has any other questions, please do enter them in the chat box. But with that, we'll jump right into the first question. So Dr. Zainab, it's clear that the COVID-19 pandemic, as mentioned by Professor Ruff, has really negatively affected cancer screenings and care and ultimately mortality across the country. Can you share more about what you've seen in your practice as so much of our healthcare resources have been shifted?
Yes, thank you very much for the opportunity. Working in a hospital that's sort of been one of the big hospitals and really in the front line as far as COVID is concerned, we've really been affected by COVID. Our cancer numbers of new patients in 2020, we saw 20% less new cancer patients. Our breast cancer surgeries went down by about 20%. So one wonders, what's happened to all of those patients. When we saw in 2019, we saw over 600 new breast cancer patients. And in 2020, we only saw 512. So what's happened to those patients that haven't been diagnosed? As Professor Paul Ruff, and thank you very much for really giving them an idea of the reality and the disparities in this country. So I think we may be a little more fortunate in the urban area of Cape Town with the resources that we have at our, we have easier access to breast cancer clinics, etc. But unfortunately, all of that, COVID has affected all of that. And we don't have access to mammography. So with breast cancer specifically, there was an NGO called Pink Drive that would go out and do mammograms in the community. Nothing has happened over the past 2 years because they have no money and because of COVID. COVID has affected the funding to many NGOs that really assisted in our work. We do have other projects on board that are funded outside of governmental funding. Things like the Pink Drive, sorry, not the Pink Drive, the project, we've got a project Flamingo, and we've got projects where doctors would go and do extra surgeries to try and catch up. We're hoping to get assistance from Gift of the Givers to help us with our backlog as far as mammography is concerned and scans and MRIs. So we really are dependent on a lot of donations to try and work optimally. And that's not ideal. That's not ideal. One of your speakers spoke about equity, and there's absolutely no equity in this country. You think about it, in the state sector, we have, and I'm not talking about medical oncologists, Prof. Ruff, because I know there aren't many medical oncologists around, but as far as clinical and radiation oncologists are concerned, we have 39 in the state sector in South Africa, providing care to 80% of the population, whereas in the private sector, there are 194. And this is really new data from SASCRO, our big organization. So it really is completely inequitable. You can talk about wonderful innovations in healthcare and beautiful drugs and all of that, biological treatment and personalized medicine, but we are still stuck by, we need education in primary healthcare clinics to educate the primary healthcare physician, doctors and nurses to be able to recognize cancer first, so that they can do whatever needs to be done and refer appropriately. But it also doesn't help to have huge, beautiful cancer screening programs, and then you don't have anywhere for those patients to go for treatment. Because in certain, so we're fortunate in Cape Town, we don't have any waiting lists for radiotherapy. But go to KwaZulu-Natal or some other provinces, you'll find that people are waiting months for radiotherapy. So, the inequities are really very, very striking geographically in this country. Yeah. So for me, the bottom line is Yes, we've really been affected with COVID. We do need help. We need help to catch up. But we're not the only place that needs help to catch up, because I mean, there's lots of research done in the UK, in the States, showing how screening has been affected by COVID. But we really do need investment in education and training, awareness programs to educate the public about screening, and then of course, facilities, equipment, etc. So we need lots, but we do have the will, and we do have people on the ground that are willing to actually take this forward. So hopefully this whole dialogue will be able to yield something. But I really feel that we need to work from the ground roots up. I mean, we can have companies like Amgen, beautiful, and MSD telling us, oh, there are all these wonderful drugs that you can get, and yet cancer drugs are more expensive in low and middle income countries than they are in high income countries. That's true, isn't it? So, I mean, how does that account for that? Commercial companies want money, want to be paid. That's how they run. That's how they create all these beautiful drugs. But we really need a little bit more basic stuff here on the ground. Thank you. And thanks to CANSA, by the way. Thanks to CANSA for the amazing work that they do, the amazing work that they do for corporates. And I also want to know what CANSA does in the primary healthcare arena, where 80% of the population actually have to attend. Thanks.
Thank you so much, Dr. Zainab. I see Professor Paul, you have your hand raised.
Yeah, just to make two comments about what Zainab has just said. Number one, you said there are 39 radiation oncologists in the public sector. There are only 7 medical oncologists. So it's even worse than that. But it's not a competition as who's worse. It's just an indictment on the whole system. The other issue is, and I mean, you touched on that in your sort of mention about corporates and high cost medication, etc. I mean, I think one thing that is needed in this country, and it's something which doesn't happen, and that's because of a number of challenges, and that's proper private-public partnerships. There are attempts to do it. We all go and we raise a bit of money here and we raise a bit of money there. We've just opened a new cancer clinic at Chris Varney Baragwanath, which never had one until this year. COVID actually gave it an impetus, which was a good thing about COVID. But it was funded by money from the private sector. We got funding from the Bristol Myers Squibb Foundation, which funded setting up this clinic. And if it wasn't for that, a lot of things wouldn't have happened. But the problem we have is that it's great. We can go and get private funding if we go out there and get it. But the problem with private funding, it's not always sustainable. And there has to be far more sustainable cooperation between the public sector and the private sector if we're ever going to get anywhere. It's very nice to get big donations and set things up, and we can do some very good things. But to make these things sustainable, it has to be done in a more formal fashion. And unfortunately, the gap between the private and the public sector is significant, and in some ways is not getting better. The ideological reasons why the Department of Health doesn't want to deal with the private sector, ideology is a major issue. It's not the only one. The public sector, you said so, the private sector, you said so yourself, Zainab, about them making profits. You're absolutely right. There is a profit motive, but it is possible to actually bring prices down. And we've actually, sometimes you actually can get the prices down quite considerably and we've seen that with state tenders, especially when there's a bit of competition. You look at trastuzumab in breast cancer, it used to be 25,000 Rand a dose. We're now under 5 and probably getting even lower. So, there are ways of getting prices down, but unfortunately, we have a situation where pharmaceutical companies have monopolies and they maintain very high prices. And I can see Zweli sitting over there. who is one of the guilty party when it comes to this situation, and maybe he can comment about it as to what we can do to provide access to equitable access to some of these amazingly good new treatments that are not available to most of the patients. So maybe I'll stop there and let really take over before I say more about this. Thank you.
For sure, certainly. May I provide some insight?
Please do jump in, Zweli.
Fantastic. Thank you very much, everyone. Thanks, Professor Ruff. I know, last time we had a conversation, we had quite a robust discussion around this. And I think the first port of call that I would put forward is you would struggle to encounter any pharma company, certainly amongst the IPASA members with regularly, that isn't supportive of mechanisms to avail and broaden access to oncology innovations within the country, certainly, let alone just the continent. But there are certain things that do limit the availability or how wide our innovations are availed within the country. The one issue is what you spoke about, and I think Dr. Zainab also spoke about it, is that the system in itself is certainly not geared to utilize some of these innovations in a broad manner. And that's something that collectively ourselves as pharma, but also government needs to play, a role in ensuring that we capacitate the system to roll out these innovations and diagnose patients much earlier on. Because essentially what we all want is, for less and less patients to be diagnosed later on in life and to need these innovative therapies that are, I'll admit they tend to be expensive. But in my opening remarks, I think you may not have been part of the discussion at that time. I did allude to the impact of the legislative landscape that we operate within. One of the major sort of curtailing factors that we have to deal with as pharma, in collaboration with the Ministry of Health, is the fact that South Africa continues to be referenced from a pricing perspective by higher sort of or wealthier markets. The latest example that I can put to the fore is Saudi Arabia, and the Saudi Arabian issue arose, I think, earlier this year. It's a matter that we've raised with government. And it becomes difficult for us as the pharmaceutical companies to push back on that without government support, because global referencing does have an impact on the price points that are available within the country. That isn't the only constraint, though. Part of the constraint is also around the fact that it is not possible to implement access solutions within the current legislative environment. SCP is a limiting piece of legislation, which we continue to engage the pricing committee on. Now, there are matters that are challenging in the sense that, there is differing views around where the mandate sits to allow or approve for access solutions, whether it is within the pricing committee, whether it's CMS, whether it's SAPRA, and these are conversations that we are constantly having in the back end with the Ministry of Health. But certainly, I think from all the fund manufacturers that I've engaged with, we all have proposed multiple solutions related to access solutions that could broaden access to these innovative products immediately within the country. Unfortunately, though, we have to operate within the ambit of the legislative environment that we find ourselves in. I think the next question that you may ask is, well, why don't you just take a price reduction? Part of the response to that is this global referencing issue that we spoke about, and it isn't on the horizon for our Ministry of Health to address. And the other part is often price reductions don't shift the needle. Less than 12 months ago, about 20 months ago, we took a significant price reduction on one of our oncology drugs. And it simply did nothing in terms of broadening access. And so we have to think about other mechanisms to address the needs of patients. And I certainly do think that access solutions do provide those mechanisms. those access solutions have been shown to be effective in other parts of the world. And I do think that South Africa needs to go along that route.
Thank you so much, Zweli. I mean, I think we all agree that access is a priority, and we all need to be holistic. And when we think about, what are the various factors and solutions impacting access? Paul, I do see your hand raised. I just want to, in the interest of time, move to the next question, but we certainly look forward to kind of continuing the conversation on these and many other issues in various fora. So the next question is really directed at our government representatives. As the connection between health systems and economic strength has been increasingly clear during the pandemic, many governments around the world have started including a broad range of departments and ministries into national health strategic planning. I'm interested in hearing from our government representatives, how should departments, usually outside of the Department of Health, such as industry, science and innovation, finance, labor, and others, really work together with the Department of Health to strengthen health systems and the health of employees. So to start, Claudina, could you please share with us some of the key research and development platforms in place during the pandemic that have successfully supported South Africa's journey through cancer?
Well, yeah, thank you for that. So first of all, Zweli, you are holding a red rag in front of me. Can we start talking tech transfer? And then we can start looking at what we can actually achieve in bringing down some of those costs. I think we sufficiently during COVID actually showed that South Africa's got the ability and we've got the science behind this. Well, the fact that we are being punished for the fact that we've got the science behind us, that's another topic. But we do have the scientists and the industry that is actually quite happy to start looking at local manufacturing of a number of the important cancer drugs. And we have the ability to do monoclonal antibodies. We do have the ability to do the APIs for drugs. And that is something where we need the big pharma companies to actually to assist us and walk with us on that way forward. The mRNA hub that's being established. mRNA is the ideal opportunity to actually start looking at how to manufacture treatments for cancer. But not only that, we also got the plant-based extraction systems that we actually can grow monoclonal antibodies in plants at a fraction of the cost. And this is where we keep on asking pharma, work with us. We can do it. Allow us to have access to your patents, that we can show you we can do it and we can work together. And this is my plea, and I've been saying it so many times. But besides that, one of the things that we've been with what COVID has also demonstrated is our ability to do genomic surveillance. And the genomic evaluations that we were doing it for cancer anyway. We are doing it for HIV. We are using a lot of HIV, cancer research and technologies in trying to find an HIV solution as well. So there's a very close link between that. And one of the things that we've done is to create with the Stellenbosch University actually a BRCA test. The BRCA test was adapted to South African populations, but apart from that, we actually are in the process of finalizing a point of care test that will give you the same readout than what you do normal, very expensive tests. And that is then so that it can bring actually diagnostics to the clinics and say, here is a PCR equivalent that we can do those diagnostics at the clinics, but at the same time, we are personalized that we can test, for example, will it make sense to use a specific drug on that person's cancer? So we're busy working into that, and the first test is out there, the BRCA one is out there. We are now looking at how can we then adapt it to things like prostate cancer, and then how do we then roll it out into the public health sector as such. The other component that we were looking at is looking also at new radioisotopes that can be used in radiology, ones that are more targeted for specific components. And one of the studies that's ongoing at the moment is actually to see what's the effect of HIV on radiology. Where's that tipping point? When do you burn the patient? And where do you need to adapt your dosage and things like that? So we're also doing those kind of things to provide better care in the end for patients as such. So there's a lot of work happening behind the scenes that we are doing, and then, yeah, to see how we can then assist the Department of Health in providing cheaper and more access to cancer care. Thank you.
Thank you so much, Juanita. I know that Candice from Amgen may have to drop off soon. Thank you so much, Candice, for joining while you can. Rashmi, I wanted to turn it over to you as well to share more about how your department is working together with the Department of Health and others to really drive, investment and activity in the health sector as a means to further economic growth.
Thanks. Thank you for that. And I think key to this kind of conversation is really about working in partnerships. Because even as the Department of Trade, Industry and Competition, in order to be able to drive the manufacturings, one needs to take from the Department of Health the priorities that have been prioritized for the country. And so we, by far, one cog in this integrated value chain, if I can call it that. So even though we provide this environment to be able to have more manufacturing being done, but we work in tangent with other departments to leverage off the support that we can also rely on them, because even when a company comes into the country and wants to set up a manufacturing facility, it's a number of strategic engagements that are involved in executing to be able to put that facility on the ground itself. And so the partnerships and objectives and mandates of the different departments and the support that they offer become part and parcel of the business case that we help with building. So over and above saying that South Africa, is an attractive destination to place your investment, but there are many different instruments to be able to look at that investment, making a commercial case or compelling arguments to be able to place that investment here. And so it runs, a number of pillars. So we work together with the Department of Science and Innovation. We work together with the financial institutions. I mean, these financial institutions being the Industrial Development Corporation, the National Empowerment Fund, the Development Bank of Southern Africa, your Public Investment Corporation, some of the financial institutions that are key to be able to drive the financials behind it. Within our own department, we have an incentive division that we facilitate those engagements with. And I think with the pandemic of COVID, we've seen how government departments and private sector have come together very quickly to be able to create dashboards and to be able to ensure that the public sector and the private sector had adequate supply and demand of products. We also were able to see, through interventions of both private and public sector in terms of how funding was reshifted, how, adaptability and agility of the different institutions to have products, available to patients and to hospitals that required it. We also saw adaptability of private sector working with government to be able to reshift and reconfigure their production lines so that they could bring the relevant products, especially in terms of PPE, with regards to ventilators, because you had to use the different sort of technologies and the different institutions leveraging their expertise to be able to roll out very quickly the products that were required for patients that required those, are in demand and on need itself, and to not have further breakages or further supply and demand chain interruptions affecting access to these products itself. So I think, critical to this is it's a value chain approach, but more importantly, it's to be able to identify the various stakeholders and to be able to dialogue with those various stakeholders in terms of how their mandates impact and how the company's mandates impact, and to be able to find that win-win situation so that everybody benefits from these investments that take place, but everybody also then has access to more affordable healthcare, and to be able to just build on the current healthcare system so that it becomes much more robust and resilient. Thanks.
Thank you so much, Rashmi. So you and many of our panelists actually have really made a lot of mention about the need for strong public-private partnerships. We've seen this throughout the pandemic. Rashmi, you just described how that was effective in ensuring the ramping up of manufacturing and strengthening the supply chain for PPE and other materials. So to delve further into that topic and how various actors across government, civil society, and private industry can work together, why don't we start with the private sector? Sizweli, can you speak a little bit about how private industry is really playing a role to ensure that South Africans are supported across the full care continuum? What types of programs you believe you would be involved in together with the various stakeholders? And again, to Professor Paul's earlier point, this is really about sustainable partnership, not about charitable donation or simple exchange of goods and services via contract. So Zweli, over to you.
Certainly I can. I think what I will do, it's always difficult to speak on behalf of the entire private sector, but what I can do is speak around the work that MSD is doing in the space. And as I was listening to the other speakers, a lot of what they were mentioning speaks to the areas of investment that we've focused on. So we also share the belief that a strong primary healthcare system is critically important, just in terms of broadening community-based healthcare access, sort of encouraging early health-seeking behavior, and potentially increasing sort of the appropriate screening and early diagnosis. And in that regard, what we did, was invest a significant amount of money through our foundation in Unjani clinics, which is a community-based network of clinics that is almost sort of decentralizes healthcare, focuses on decluttering the public healthcare environment, and offers many of the services that are availed in the public healthcare space within these healthcare centers that are within the communities. And the thinking behind that is that by increasing access to these primary healthcare centers, you actually would be encouraging people to, exhibit this early health-seeking behavior. And we believe that this is a model that we will continue investing not only money in, but time, effort, as well as educating the healthcare practitioners that are servicing those centers. The other thing that we do, and most pharmaceutical companies do, is that we actually spend most of our budgets on healthcare practitioner and patient education. We believe that this has a direct impact patient outcomes as it aids diagnosis and treatments. And so you'll continuously find that we're investing in webinars, seminars, CMEs, and this is to improve healthcare practitioner skills and improve the quality of care that's disseminated to patients. And we also exposed healthcare practitioners to global as well as local best practice. We invest in research, and this is research through non-conditional grants that we provide to NGOs. And what this does, it allows us to understand the gaps that we currently have in our environment and find models or proposals based on global best practice that could lead us to where we want to be. We ideate around healthcare funding. This is another thing that we spend a lot of our time around. And in this regard, we've done a lot of work with, for example, some of the banks to look at ways and means to provide, different kinds of funding that would avail people the opportunity to access healthcare that they previously perhaps wouldn't have been able to access. Me personally, it's always bothered me that sort of the buying process for healthcare is practically the same as the buying process if I were to go and buy a packet of chips, where, you know, there's a price, I have to pay now. If I don't pay now, I don't have access to that particular product that I need to save my life. And so we've spent quite a lot of time working with banks to find ways and means where we could utilize the science that we have to avail mechanisms of funding that would allow patients to pay off their healthcare, you know, over a longer period of time. And we realized that our expertise is within the science. And so we have to partner with those that have expertise from a financial perspective to avail these solutions that would aid patients. We've also worked with you know, partners such as Hanover Re in developing insurance products. There's an IO insurance product that is available now in the market, where a patient who is diagnosed with cancer and eventually treated with IO therapy would get provided with some funds that would be able to pay for the therapy that they've been prescribed by their doctors. And one must realize that all of these solutions that we're working on from a funding perspective are not specific to our products. You know, if they are for IO therapy, it's for all IO therapies that are available on the market. If we do get to the point where we find, you know, the sweet spot around, you know, long-term healthcare funding in partnership with the banks, it would be for a multitude of different products, certainly not just MSD's products. The really impactful work that I think we are doing is we are continually engaging with policymakers and policy custodians around access solutions and what we term ARM models, because we quickly realized that we shared the same desired outcome, and that's improved patient access. And so our engagements are not about finger pointing, but rather about, you know, finding solutions that can sort of deal with the hurdles that the policymakers share with us. We try to understand what those constraints are, and we continually ideate around how we can overcome those hurdles in partnership with them. And certainly, if I look at the quality of engagement over the past 3 years, certainly the past 6 months has shown that there's a significant improvement. And, you know, the onus is on us as well as government to find viable solutions around the challenges that they've put forward. But it's an ongoing piece of work. And as I said, we can't really speak for the entire private industry, but certainly I can speak for MSD and say, you know, these partnerships are essentially what keeps us busy for 80% of our time.
Thank you so much, Zweli. It's great to hear that if we can sort of align around this goal of improving access, we really can then think about what are the solutions that work with all the various stakeholders, incentives, and individual and unique constraints. So Paul, I see you have your hand up as well. Would you like to jump in?
Yeah, I must want to comment about what Zweli has just said, because although he said some very noble things, there are two issues which I think worry me significantly. One is you claim that you're spending a lot of money on education. It's not education, it's marketing. All the CMEs, etc., that are done by pharma are forms of marketing. I've yet to go to a so-called pharmaceutically run meeting that is not marketing. They're always geared towards your products, or if it's not your products, your type of products. So I don't think it is correct to say that you do fund open education every time it's based on your products. And I think it would be a fallacy to say that you are really providing true CMEs. You actually are marketing your products in one way or another by doing that. I know I'm being hard, but I've been around for a long, long time with this, and I think this is something which we need to be very careful. We need to move away from these pharmaceutically managed CMEs and have maybe the concept which you did mention of having sort of grants towards non-pharma funded education. The other thing which is related to that, and I think is one of the big problems we have, is that you speak a lot about what we do, what MSD does, which is great. And I know MSD does phenomenal work in many areas. But one thing I never see, and that is pharma companies working together. They're always competing with each other. So we never get projects that are cooperative projects with multiple pharma companies. Each company is trying to do its own thing, as a result of which you're getting all sorts of projects, which are fantastic, but they're not coordinated. There needs to be a situation where the pharma industry and all industries, and also it's the same thing applies to research in this country, where people stop being so sort of siloed. Everyone is doing everything for themselves and not working with other people. The level of collaboration is lacking in this country. We do not get researchers in academia collaborating. We don't get pharma companies collaborating with each other. And I think that we need to try and move beyond that. I know that the pharma industry is a business and you have to make money, and we strongly support that. Because without pharma making money, we'll never have new developments. And pharma is critically important in the development of new treatments. And we all are very grateful for that. Without pharma, we would be nowhere. But on the other hand, there also has to be more collaboration. We don't need 20 PD-1 inhibitors, which there are actually out there if you look for them around the world. There's no collaboration. Everyone wants to do their own thing. I think that the time is that we need to have more collaboration between pharma companies. We have more collaboration between researchers. And the biggest problem of all, which is, and this COVID has shown this very, very, very badly, well, the lack is, and that is to move away from nationalism, that every country wants to do its own thing. Every country thinks, you know, says to hell with everyone else, we're only interested in ourselves. And of course, the biggest culprit in the world when it comes to that is the United States of America. But when, you know, people, there needs to be more worldwide collaboration, but it doesn't happen. Everyone is interested in themselves. And I think COVID in some ways has brought out, although it's brought out the best in some people when it comes to research, and we've seen that, it's also brought out the worst in a lot of people and in a lot of countries. So I mean, I'm being a little bit naive in what I'm saying to expect that, you know, this can all be sorted out. But I think it is something we need to seriously think about. Thank you very much.
I do see, Zainab and Zweli, that you have your hands up. We're just 1 minute over time right now. So I think we can look forward to sort of continuing this conversation in different fora. I think this is a really engaging, given that we're running already over, a really engaging, informative discussion. Professor Paul, to your point, I think we all agree on the need for greater collaboration, not only, you know, within South Africa, but globally as well. And the need for the various stakeholders to come together across civil society, government actors, and private industry, and sort of work creatively, collaboratively, and, you know, without pointing fingers as such, but really trying to move towards a common goal. So I'd really like to thank everyone for joining here today, and I'll turn it over to Lorraine to give the final wrap up, or I'm sorry, Elise.
Thank you so much. I just want to firstly thank every speaker for your very enlightening presentations. And I want to thank everyone who participated for the robust discussions here this afternoon. Highlighting the state of cancer control in South Africa, the need that we have to strengthen it. But then the strong call for action came through that we actually need to forge more public, private, and civil society partnerships and continue with this debate, because we need coordinated approach towards strengthening cancer control. Firstly, by starting at a very awareness level so that people can come and present when there are already early warning signs, that we should strengthen early detection, but all include that we should include empowerment, engagement, all linked in eventually to integrated people-centered services at all levels of care. So my call is, Let this not be the end of our debate this afternoon. Let this just be the beginning. And I want to thank then all of our participants, all the representatives of government officials, our private partners, all participating here, the US Chamber, all your representatives. The rest of the audience, I see that our chairperson of CANSA's board also joined. Thanks, Vio, for your interest. So I want to thank everyone. I think it was the webinar, to my opinion, have met the ultimate aim that we want to stimulate thoughts and start with the debate. So as I've said, this is not the end of it. Thanks to everyone.